Your other big group of receptor blockers to scan here are the beta blockers. Beta blockers are found in every cardiac pathology as part of their treatment. It's just an incredible class of drug. And here we review first what we expect from beta 1 blockade. Recall that beta 1 receptors are primarily in the heart, but also in the kidney, and right now we're going to add a third place that we had not put in our general table. It's also found in the eye, and in the eye decreases aqueous humor production. So that like this we'll be able to use it to decrease intraocular pressure in glaucoma. But as mentioned earlier, we'll talk about glaucoma in the next chapter. Rather, let's discuss well what we achieve with beta 1 blockade in heart and kidney. In the heart, you have from SA and AV node, beta 1 blockade resulting in bradycardia. In the muscle, particularly in the ventricular muscle, you're going to see decreased contractility with decreased stroke volume, decreased cardiac output. In a nutshell, meaning decreased oxygen demand. What could be uses then that I could graft on my beta blocker just based on the heart effect? Look, from decreasing SA and AV nodal activity, I could use this for what I call supraventricular tachycardias, or SVTs. An example of SVT could be an atrial tachycardia, and slowing SA conduction could itself decrease the rate of arrhythmia in the atria, but slowing AV node, remember, will protect the ventricle from the fast atrial beat. So we'll use them as a class of antiarrhythmic. As far as working in the muscle, if they decrease oxygen demand, they will be used in patients with angina. They will be used in patients with myocardial infarction as a history. As a matter of fact, they are so efficient that they have been clinically proven to not only decrease the occurrence of an MI if you're an angina patient, but if you're an unfortunate MI patient, to improve your survival when used acutely, and when used chronically, to decrease the recurrence of another MI. So they're drugs that have to be used in ischemic heart disease. As far as decreasing renin release, well, this is the other aspect of our story. And when you decrease renin release, you will decrease angiotensin II, which is a powerful vasoconstrictor, so it will decrease TPR. And you will also decrease aldosterone and therefore decrease salt and water retention, so decrease edema. Well, what could I use that for? Let's think. If I can cause a decreased angiotensin II and decreased TPR, that's going to be the primary basis for using these beta blockers in management of hypertension, HTN. And finally, if I also decrease aldosterone at the same time as I decrease heart work, decrease vasoconstrictive tone, then you know I'm going to be able to be used in congestive heart failure. That means you're going to see beta blockers in your cardiac section as antiarrhythmics, as antihypertensive, as anti-CHF, and as anti-anginal drug. Unbelievably, therefore, they're found in every heart pathology out there. Now, as we're looking at this, another key point from this. Normally, when you lower someone's blood pressure, didn't you expect reflex tachycardia? You did, didn't you? Well, can I get a reflex tachycardia while on beta blockade? Absolutely not. There will be no reflex tachycardia. I'm actually causing bradycardia. That's good. What else is going to be good? Let's remember, when we lower blood pressure, kidney's response is to produce renin. Will I see renin? I can't. It is dropped also. So no edema when I use that drug in managing hypertension. You now have a drug that we use in hypertension management that causes no reflex, no edema, no homeostatic regulation. You know, it means probably beta blockers are often the initial treatment of mild hypertension. It's particularly true in the Caucasian populations in the United States, particularly from the point that Caucasians tend to suffer more from high renin hypertension, and beta blockers will be very well fit for that. Does it mean I have no side effects? Be careful. Just from the beta 1 blockade alone, can I slow the heart too much? Hey, let's remember, what is the legal definition of death? You know that? To have a flat EKG, not a flat brain wave type of EEG, but I'm talking the electrocardiogram showing no wave activity, you are legally dead. A beta blocker in overdose will cause AV block and will potentially stop the heart. Not too good. So you know not to do it too much. In the margin, in your book, notice what is said about beta blockade overdose. The use of glucagon is actually the best drug to reverse a beta blocker overdose. You know, the primary reason behind this is when you've been chronically on beta blockers, your receptors have upregulated, are very sensitive. So if you were using a beta agonist to remove the blocker from the receptor, you would probably end up with exaggerated cardiovascular responses and as such, life-threatening arrhythmias. So the idea came to use glucagon through its GS-coupled receptor to increase cyclic AMP in the cells where beta blockers prevented that from happening, and in doing so, reversing the symptoms of the beta blocker overdose. Plus, beta blockers are going to cause issues with generally metabolism and levels of glucose, and glucagon will raise that glucose too. So glucagon antidote in beta blocker overdose. And as I'm looking at the beta 2 blockade, there is nothing in there that I'm going to like. You see, a beta 2 blockade has no clinical uses whatsoever. First, it's an issue with cautions. When you block receptors, remember you have no effect of your own until you need that receptor with an agonist. The endogenous agonist is epinephrine. Epinephrine comes in situations of stress, of need. And here's one stress. Imagine 1 second you're an asthmatic. If you're an asthmatic, you're getting bronchospasm. Every time you have a bronchospasm, your adrenal medulla produces epinephrine to bronchodilate, or you're taking beta-2 agonist in your mouth in order to bronchodilate. If you have a beta-2 blocker on board, these drugs are not going to work. As such, you will precipitate bronchospasm in an asthmatic. You exacerbate it, make it worse. Don't use beta blockers in asthmatics unless you really have to. Contrast, if you're not an asthmatic, sitting on a beta-2 receptors in your bronchioles will do absolutely nothing. It's no efficacy when you have a blocker. So as such, never understand it that the beta blocker would cause bronchospasm. Of course it doesn't. If it did, then everyone would have an asthma attack. No, rather, don't use it in an asthmatic because it would aggravate the asthmatic's condition. How about vasospasm? Every time you have a vasospastic disease, and you know such vasospastic diseases might be Raynaud as a phenomenon or as a disease, phenomenon when there's underlying disorder, maybe like scleroderma or SLE or maybe smoking and Buerger's angiitis, something like this. Or worse, Prince-Meadow angina. That's the rare form of anginal pain associated with coronary vasospasm. Whatever the case might be, if you have vasospastic disease, a beta-2 blocker will actually again exacerbate and trigger vasospasm in those patients. Sitting on a beta-2 receptor when I don't need it does not cause vasoconstriction. Think of it a second. If it was causing vasoconstriction, would we have said that it improves survival of our patient who have angina or MI? Of course not. The sign that antagonists have no effect. Only contraindicate them if you have vasospastic disease, particularly if you have Prince-Meadow. In Prince-Meadow angina, you could actually trigger the MI if you use the beta blocker. Remember, in Prince-Meadow, use calcium channel blockers, or maybe nitrates, but certainly not beta blockers. We'll talk more about this in the cardiac section, promise. And then the third and final point of beta-2 blockade are the far-fetched metabolic effect. These metabolic effects will be particularly upon fasting. So as you stop your food and you go in between meals, biochemically speaking, you depend on gluconeogenesis and glycogenolysis to provide glucose for red blood cells, brain cells in between meals. In order to do this, you need particularly the effect of epinephrine on beta-2, as well as, of course, glucagon, growth hormone, cortisol, and so forth, you can understand that then a beta blocker may actually decrease glycogenolysis, decrease gluconeogenesis, and upon fasting may result in hypoglycemia, decrease glucose. Well, hypoglycemia, by the way, is no better than hypoxia to our brain. It is as detrimental for neurons not to have glucose as it is not to have oxygen. This is the only thing they use in order to get ATP. That fasting hypoglycemia is a problem. And the people who will be most affected by the fasting hypoglycemia will be our diabetic patients. Because in a diabetic, I know I'm using drugs that already cause a risk of hypoglycemia in between meals. That's why we actually tell our diabetics to eat many small meals during the day to avoid the fasting world so that they don't have hypoglycemia from their meds. If they're on a beta blocker, it will worsen that risk. On top of it, every time you have a hypoglycemic event, one big sign is the tachycardia. And what is happening to tachycardia with all beta blockers? Well, indeed, it's cancelled. So you have three conditions where you avoid beta blockers. These are asthmatics, people with peripheral vascular diseases, particularly Prince metal, where it's an absolute contraindication, and diabetics. In these patients, we want to use other drugs if possible than beta blockers. Maybe we're going to try beta-1 selective blockers, but you know that selectivity is all a matter of dose. Selectivity always looks good when it comes from the drug company and when it's done in vitro in a test tube. Once it gets into our human body, selectivity is a completely different issue. I always want you to think selectivity is beta-1 more than beta-2, much more than beta-1, not at all beta-2. Huh? So it would just be safer. Talking about these points, let's look at this big table. And this table will look for us at several beta blockers and some classic pharmacokinetic considerations. First, how do you recognize a beta blocker? Well, it's easy. It ends up in OLOL. And anything that has OLOL, and notice I'm circling the O here, huh? Not ALOL, not ELOL, but OLOL. If it's OLOL, it's a beta blocker. Problem? There's a couple dozens of those out there. And although we don't need to know the size of the box and the price, we certainly need to know how to differentiate them. They have some key points. First key point, who's beta-1 selective, meaning beta-1 much more than beta-2, and who's not? Well, this is easy. Any beta blocker that starts from letter A through letter M is going to be a beta-1 selective blocker. You know, for example, if I give you the drug betaxolol, or if I give you the drug esmolol, what would you tell me based on what we say? That it's beta-1 selective? Of course. Between letters A and M, it must be beta-1 selective. See, it's not too tough. From letter P onward, then, you are non-selective, like propranolol, timolol, and so forth. Why would I want beta-1 selectivity? If you want to see what you want beta-1 selectivity for, look underneath your table. Beta-1 or cardioselectivity means safer in asthmatics, diabetics, and people with peripheral vascular diseases. Of course, less beta-2 pharmacology. But you see it said safer, it didn't say safe. So that it means if you could avoid them, you'd be just that much better off. Next point in the table. The next point in the table is to look at ISA. Now, what on earth is ISA? ISA, if you look underneath your table, stands for intrinsic sympathomimetic activity. Note that there are two drugs that have intrinsic sympathomimetic activity, the drugs acebutolol and pindolol. Analyze the word for me. Intrinsic belongs to the drug, sympathomimetic. It means it mimics norepinephrine. How can a blocker also mimic the agonist? I think you know the answer from your general principles. A drug with ISA is a partial agonist. These are your first real partial agonists to review in the book. Let's recall that partial agonists have duality. By themselves, they behave as agonist. In presence of a full agonist, they behave as blocker, but they always have a ceiling on their effect, meaning they might be less effective, but they're also far less toxic. Look at what we worry about with beta blockers. The AV block and therefore stopping the heart. There will be less bradycardia because of being a partial agonist. That can be construed as an advantage, of course. It also means that if you are non-selective, in which case it's not acebutolol but pindolol we'd be talking about, then there could actually be agonist activity on beta-2s with actual slight vaso or bronchodilation, and as such could be a little bit safer to use in people with certain vasospastic or asthmatic type of diseases. Well, that's only true of pindolol. It can make it for a nice point on the exam. Which of the following drug or which of the following beta blocker can also bronchodilate? Can you imagine? I could give you a list from A through O of blockers with olol as an endpoint, and there would be only one to pick, the drug pindolol, which is a non-selective partial agonist of beta receptors. So make sure you highlight this well. As to the changes in plasma lipids, let's go back to the table. Blood lipids have to increase with beta blockers. They have to, because with beta blockade, I am going to impair lipolysis, impair the actual breakdown of lipids, particularly by the liver. Well, look then who comes as a notable exception, the partial agonist acebutolol and pindolol, and very classically, if they're partial agonists, they don't block lipolysis completely, they may even stimulate it a little. So as such, no issues with hyperlipidemia with those two beta blockers. Well, we then have one final thing, which is in the table also, which is sedation. And let me highlight it differently. Sedation has nothing to do with the ANS and the periphery. That is a central effect of beta blockers. Norepinephrine, just like acetylcholine, is an excitatory neurotransmitter. It's a neurotransmitter that stimulates our brain function, that keeps us awake, aroused. You block beta receptors, you get CNS depression. And the mildest CNS depressant effect of a drug will be a sedative effect. Note for that matter how much propranolol, the prototype of beta blockers, is sedative. It's one of the most powerful sedatives out there. You know, it's sedative enough that we can use it for that. We can actually use it to calm down people with phobias, particularly social phobias, agoraphobias. We can use the CNS depressant in migraine headaches, in essential tremors. So it gives propranolol the possibility of being used like a CNS drug, which is pretty impressive right there. But here's the other issue. What if I was taking a beta blocker then with a glass of alcohol? Or the beta blocker with a sedative drug like an antihistamine? Then you know you would have additive CNS depression, and there's a fine line to cross between being sleepy from sedation or being sedative enough to become comatose. So with this, always worry that beta blockers as a rule are strong CNS depressant, particularly propranolol. If you know propranolol so well, you may want to highlight in that same column the drug atenolol. Atenolol is not sedative. Atenolol is water soluble, and if it's water soluble, it does not cross the blood-brain barrier. So as such, this is an example of beta blocker that would be non-sedative. Well, imagine the following scenario. You have someone who has an angina history. You want to put them on beta blockers, but they're also dealing with maybe benzodiazepines to treat insomnia. Which beta blocker would be safer to use with someone taking benzodiazepines for insomnia? I'm sure you've chosen atenolol, and you would be absolutely fine. Atenolol would not add on to the CNS depressant effect of a benzodiazepine. I think if you invent yourself a clinically relevant scenario, it'll help you work that table out well. Realize it's all straight recall. You don't invent it from seeing olol. You've memorized it. And to memorize it, you're going to need to repeat it, make stories to make sure that you can keep it, because this is how you make choices more adequately on your step 1 question. In this slide of beta blockers, it reminds us then in writing the general uses that we derive from the pharmacology. We've talked about using them in angina, hypertension, post-MI, any of these beta blockers. As far as antiarrhythmics, they'll be called class 2. FDA has only approved propranolol, acebutolol, and esmolol for that use. Notice esmolol is a beta 1 selective blocker. We're going to use these drugs also to decrease aqueous humor production, such as timolol as eye drops in glaucoma. If you want another one here, you can put betaxolol, which is also used in glaucoma. And finally, we can use beta blockers, particularly propranolol, for CNS type of issues such as migraine, performance anxiety, essential tremors. Notice that then there's one use that we have not explained, the use of propranolol in thyrotoxicosis. Wow, so someone with hyperthyroidism, or I know hyperthyroidism causes tachycardia, and with tachycardias, why not use a beta blocker? Well, then you could use any of the beta blocker if it was only tachycardia that was your issue. No, there's something you don't know maybe about propranolol, or if you do, it's great. Review it again then with me. Propranolol is the only beta blocker that can be used in hyperthyroidism because of this. It's the only beta blocker that inhibits deiodinase. And if it inhibits deiodinase, it inhibits the conversion of T4 to T3. Obviously, therefore, it's really an anti-thyroid drug. Now, there are drugs that sound like beta blockers. You see, labetalol, carvedilol, but they're not all. It's a sign that they're not pure beta blockers. Labetalol and carvedilol also have alpha blocking activity. They'll be used in CHF. And the drug sotalol will be also a voltage-dependent potassium channel blocker. It will be used as a class 3 antiarrhythmic. This concludes our Chapter 3 of adrenergic pharmacology.